Since the initial prototypes in 1934 and 1978, the ophthalmic endoscopy has been optimized in size, resolution, and maneuverability. Recent technological advancements have increased the number of indications of ophthalmic endoscopy and offered two fundamental surgical advantages. 1. Bypassing anterior segment opacities, and 2. Visualization of anteriorly placed structures such as ciliary body and subiris space. In this video, we describe the surgical technique, pearls, and the learning curve of endoscopic vitrectomy for handling complex retinal detachments. The E4 endoscopic system includes a 175-watt xenon light source, a microendoscopic color camera, a microendoscope flexible fused fiber with 19-gauge microprobe which has a 50-degree field of view in water and 70 degrees in air. Endoscopy allows viewing of 360 degrees of posterior segment through non-transparent media, high magnification, and a tangential approach to anterior zonular vitreous base. In cases where there is corneal opacification but a preserved limbus, standard sclerotomies are made, whereas in cases such as keratoprosthesis, approximate measurements are taken from the center of the optical cylinder for sclerotomy placement. Microcannulae for cutter and infusion are placed after incising the mucous membrane graft to expose the underlying sclera. A third port is then similarly made for the 19-gauge microendoscope. Direct visualization of sclerotomy creation prevents complications such as subretinal, subchoroidal, or subciliary placement of infusion cannula, choroidal hemorrhage, or anterior displacement of vitreous base or retina. Vitreous removal at sclerotomy site is made possible by flexibility of the endoscope. The next step is to visualize the disc. PVD induction can be challenging because of the limited field of view and lack of stereopsis. Advanced PVR changes with anterior contractures pose great difficulties even in conventional microscopic vitrectomy. The endoscope grants surgeons in vivo perspective of structures rather than the contorted view via scleral depression. Endoscopy also offers multiple direct planes of view to reveal how anterior PVR is creating traction instead of the artificially contorted view seen through a microscope with scleral depression. Again, limited field of view and lack of stereopsis makes this maneuvering challenging. Endoscopy can be maneuvered to do retinectomy as seen here. However, the orientation and the direction of the movement of cutter to execute retinectomy is quite difficult. Fluid air exchange. Limited field of view with about 50 degrees in water and 70 degrees in air facilitates normal fluid air exchange. Endoscopic view of the subretinal space through the retinal breaks allows visualization of migrated subretinal PFCl or silicone oil. It also helps to prevent retinal slippage while performing fluid air exchange. Laser. Attached retina is lasered with great maneuverability since a laser probe is built into the microendoscope probe. And a direct endoscopic view avoids multiple interfaces, corneal haze, and gives a direct view of laser aiming beam and laser reactions. Substantial differences between endoscopic and conventional microscopic view and instrumentation creates a steep learning curve. Initially, operating while viewing a remote monitor may be difficult for hand-eye coordination. However, familiarity can be achieved with practice and appropriate bedside positioning of the monitor, which minimizes head turning by the surgeon. In addition to the learning curve, another challenge of endoscopy lies in the loss of binocular stereopsis. Shadowing is also eliminated because the light source and the camera are on the same axis. Awareness of instrument location within the globe therefore relies on monoocular clues such as the size of the landmarks, intensity of illumination, and change in focus. While endoscopic surgical planes, views, and magnification are a powerful tool for treatment of complex vitreoretinal conditions, they may not replace conventional vitrectomy, but may be an option in case with compromised anterior segment.